Hello and welcome to MedCity News' Invest Conference. My name is Arundhati Parmar. I'm the editor-in-chief of MedCity News, and we have been covering healthcare innovation news and analysis for more than a decade. Today, we're going to be discussing value-based care. Value-based care has been a buzzword for quite some time, although adoption has been very slow. Today, the assembled panel will discuss the reasons for slow adoption, but why the future of VBC is bright. So I wanted to get a chance to share and tell you who our panelists are. So today our moderator is Delphine O'Rourke, partner with Goodwin. Delphine counsels health companies, hospitals, healthcare systems, and investors on the regulatory frameworks that drive their businesses. Previously, she served as Associate General Counsel of Ascension. She has expertise in how to comply with federal laws and regulations governing access, delivery, and payments for medical care in the United States. Delphine understands how to engage in strategic affiliations and investments, including complex provider and multi-system transactions, due diligence on behalf of private equity clients, and critical supply chain relationships. She also has expertise in emergency management, public health, and crisis communications. Delphine is currently advising a wide range of companies and providers on the legal issues related to COVID-19. She is nationally recognized for her commitment to the advancement of women and inclusionary leadership. She also maintains an active pro bono practice. Welcome, Delphine. Next up on the panel, we have Francois Brantes. He is Senior Vice President of Signify Health and is also in charge of episodes of care. He leads customer development of the Medicare Advantage, self-insured employer and commercial payer markets. Previously, Francois served as Vice President of Alterum, a national nonprofit. From 2006 to 2016, he was Executive Director of the Healthcare Incentives Improvement Institute, a not-for-profit company that designed programs to motivate physicians and hospitals to improve the quality and affordability of healthcare delivery. Francois holds a master's degree in economics and finance from the University of Paris, Dauphine, and a master's degree in business administration from the Tuck School of Business Administration at Dartmouth College. Welcome to you, Francois. Jorge Galva is the executive director of the Puerto Rico Health Insurance Administration. His professional experience includes 16 years in legal practice, specializing in healthcare law, and 16 years as healthcare administrator, which includes positions as CEO at 3 hospitals in Puerto Rico and COO of a US-invested international healthcare consortium based in Santiago, Chile. He is now executive director of the Puerto Rico Health Insurance Administration that implements and administers the island-wide health insurance system. Jorge has a law degree from the Inter-American University of Puerto Rico, a master's degree in law from the Catholic University of Puerto Rico, a doctor's degree in law from the University of Valladolid, and a master's degree in healthcare administration from the University of Iowa. Welcome, Jorge. Javier Gonzalez is the Chief Growth Officer at Abarca Health. As a doctor of pharmacy and 20-year veteran of managed care markets, Javier brings a deep and diverse background to his role as Chief Growth Officer at Abarca. He oversees industry relations, commercial operations, pharmacy network, and analytics. He also leads Abarca's initiative to pursue new and innovative rebate contracts. Before joining Abarca, Javier held senior roles in leading healthcare companies, including HospiceScript and ProCare RX. He managed clinical pharmacy services, prior authorization programs, formulary management, and disease state management programs. A frequent speaker and contributor to industry and trade outlets, Javier has published papers on Medicare Part D, clinical drug reviews, hospice, and other issues. Welcome to you, Javier. So I hope you're ready for a very engaging conversation. So take it away, Delphine.
Thank you, Arundhati, and thank you for joining us today in what's going to be a truly interesting conversation with some of the leading minds in the value-based contracting space. So let's jump in. So first question for Jorge, Javier, and Francois. Value-based contracting has been criticized as too slow and not meeting up to the expectations. When, looking back for those of us who are in the space, 10, 15 years ago, it was going to be the holy grail. It was going to save modern healthcare, while at the same time, there's been a really recent surge in interest in value-based contracting. So how do you explain that?
Well, let me try to kick it off, and thank you so much for inviting me to this panel. The first, I think, as we get into the discussion today, we're going to separate out value-based contracting for pharmaceuticals, devices, medical innovations, from value-based contracting of physician groups, hospitals, health systems, around more of the payment for the delivery of care. And both are important. And to your point, I think both are equally surging, and both have been very slow to be adopted at the scale that everyone was hoping for. And I'm going to speak more to the contracting for the delivery of care and hospitals, physician groups, and health systems. And I'd say that the surge is really has been an ongoing representation of the interests of those who actually end up by paying for our care in the United States, which are the employers, and their desire to get greater value out of the ever-increasing dollars that they spend for the health of their employees and the families of those employees, without ever really observing any significant increases in general outcomes, barring some exceptions that are largely the result of new therapies. And I'd say that struggle of the surge, the demand by employers, what we see as really a responding demand on the part of providers who are willing to take on increasing risk, is being thwarted to an extent by the third-party payers, who are always in a difficult situation because on the one hand, they're asked by employers to provide large networks with easy access. On the other side, they're asked to narrow networks and do value-based contracting. And it is a little bit of a whipsaw. It is a little bit of a challenge to meet all the demands of everyone. So the market is, however, becoming a lot more rational from that perspective. There's a ton of activity around independent organizations who are coming together and really accelerating the deployment of the type of technology, the type of contracting that you need to bring the employers and the providers together. So I think the delay has been mostly a function of not only the delivery system being conflicted about, do I really make the push towards value-based payment or do I stay in fee-for-service, but also the third-party payers being constantly conflicted between what one part of the market wants and what the other part of the market wants.
And those are great points, differentiating between the various players, and we'll speak to that. And I think as time has gone on, there's been more trust that this is actually going to have traction, that they're going to see results, because there is a risk to transition. Jorge or Javier, would you like to speak out of the pharmacy side or the device?
Yeah. Thank you, Delphine. From my perspective, I'm gonna cover the pharmaceutical piece, and or the pharmaceutical piece of the pie. Right, since Rod talked about the healthcare delivery piece, which is also very important. The pressures facing pharmaceutical companies, around high drug prices, right, are not likely to dissipate anytime soon. And it's obviously been emphasized by the Trump administration, and now the most recent bureaucracy that we see is still pointing at trying to do something to control these high drug prices that we see in the industry. And I think the pharmaceutical industry has a call, and it's being called forth to try to alleviate these pressures in terms of exploring new market solutions. And one of them is the value-based agreements that have been talked about. And I just want to share 3 key insights of where I think why we haven't seen maybe a greater explosion or adoption of value-based agreements in our industry. And one is, there's an initial point of contention that can effectively halt the dialogue between manufacturers and payers, and it has to do with the transparency of how drug prices are calculated, right? And if there's not a baseline that can be established, it's very difficult for payers and drug companies, to come together to have shared ground to negotiate a value-based agreement. So I think without transparency and common ground, payers are inclined to forego, right, value-based contracts altogether. And maybe one of the reasons we've seen a small adoption. Two, operationally, it can be difficult to determine the outcome measures that need to be established, specific endpoints in time. And additional complications that can come up that we see is in terms of sourcing, administration, the cost of data management, data collection. And furthermore, payers are somewhat concerned sometimes because depending on the length of these value-based agreements, they may not have that member continue to be in that plan, right? So here they are paying for these expensive drugs, wanting to do these value-based arrangements, but they may not come to a point where there could be a return on investment for some of these investments. And lastly, and an important one is the regulatory side. When we think about what's going on with drug pricing regulations, I think there's some complications in terms of how manufacturers are dealing with the anti-kickback statutes that prohibit the exchange of anything of value and intended influence, that I think is still kind of soft ground. And even in the most recent rules that were passed, they still identify PBMs and pharmaceutical companies as ineligible, right, to be protected under the safe harbors. And so I think those three things together are some of the insights that I think have helped describe why we're a little slow in the adoption of these agreements.
And on the regulatory piece is where I spend my time, and we were hopeful that with the new regulations there'd be some relaxation, but it's not what we're seeing. And to your earlier point, there are a lot of things that the former administration and the current administration don't agree on, but pushing for or pressuring drug pricing decreases, they definitely agree on in concept as well as transparency. The question then becomes, how do you do it and how do you do it effectively? And I think, if we learn from the hospital transparency initiative, there was a lot of activity, not much on the side of results and really helping consumers understand what the drug pricing landscape looks like. Jorge, from your perspective, I mean, you're coming from the insurance perspective. What's been your experience, your insight as to obstacles to, slow adoption?
Well, I think that the points made by Francois and Javier are very well taken. And I'll add something from the perspective of a payer, and in this case, from a publicly funded program like Medicaid is in the case of the Puerto Rico Health Insurance Administration. Firstly, I want to preface my answer indicating that one of the greatest challenges that the program has in Puerto Rico is the quite accelerated increase in the drug expense. We have a drug expense that has been increasing on a 25% basis year over year during the past 4 years. And clearly that path is unsustainable over time. So we are very interested in looking at arrangements where we can actually show that we're getting the results, the clinical results that are expected from these very expensive drugs that are coming down the pike. But I would suggest to you that aside from the difficulties that Francois and Javier put on the table, the provision of pharmaceutical care for our patient population has some characteristics that make a value-based proposition hard to implement, not because of the theoretical framework, but of the implementation per se of the contracts and making sure that the medication reaches the patient properly, that compliance with the medication regime is followed, and that we can actually ensure that our insured population is taking the pills or taking the medication that has been provided to them. There's a lot of focus on value-based, but I would suggest that given the specific kind of illnesses that affect our population modernly, which are chronic illnesses, one of the characteristics of chronic illness is that it won't get better over time. What we can expect is to control the illness and prevent it from getting worse, or some of the sequela from this illness from getting worse. So control of the disease is a time-based proposition. It's not a shoot and forget thing. We have to make sure that the medication gets to the patient in time, in the proper dose, and it's taken properly for the medication to work. So I would suggest to you that in looking at any value-based proposition for pharmaceutical programs and pharmaceutical products, we have to take into consideration the end user of the product. If we don't do that, we might be bound not to get the results we want and not to get the healthcare outcomes we're expecting from the medication.
I mean, that's sort of fundamental to patient-centric care. But Jorge, you told us about, we've talked about the challenges, but you told us about how you turned a challenge really into an opportunity with a proactive assistance program with medication management in Puerto Rico. So love to hear more about that, share that with the audience, so we can also use that to pivot and talk about what are the opportunities that we see in value-based contracting. I mean, fundamentally, we're shifting from you get paid by volume to you get paid by quality. So tell us a little bit more about that, because first of all, it's a great story of how you took advantage of that challenge, and also, there's enough experience now. This is an experience that others can learn from in developing their own contractual relationships.
Sure, we had a great experience in our partnership with Abarca in the provision of medication for one of our patient populations, and one of the things that was essential in the operation and implementation of this contract was that there was an appropriate balancing of the risk in the contracting. This means that the provider of the medication, the manufacturing company, was willing to share some of the risk in the provision of the medication. What do I mean by that? There was direct support in terms of implementation, monitoring the patients, ensuring that the patients complied with the medication regime, and helping us and gather the data to measure the outcome of medication. So that was a very good example of how a successfully structured value-based contract can overcome the challenge of chronic disease and actually achieve good results that are measurable and can be repeated in time if the same structure is put together. We have a second example of that with our Hep C initiative that was started last year. The Hep C initiative also was put together on a 100% risk base for the agency. That means we assumed the entire risk for the provision of the medication and for the cost of medication. However, our partner on the other side, the pharmaceutical company supplying the Hep C drug, provided us with everything from visiting nurses to the collection of data from the patients, to ensuring that the patients were screened both prior and subsequent to the treatment, and making sure that we had achieved cure. In this case, of course, Hep C is a chronic condition, but it can be cured through medication. So in this case, we already have the experience of 500 patients that have been treated with this medication, and we have had the full support of the company in making sure that those outcomes were ensured by monitoring the patient, following up, reminding the patient to take the medication, and providing for a full platform of close monitoring of the patient population to ensure that everything went well.
So I must say, Javier or Francois, any comments from the pharmacy perspective? I think it also goes to the concept of structuring and making sure that all of the parties have a strong vested interest in the outcomes. But either of you, either reacting to Jorge's or additional opportunities that you see with value-based contracting?
Yeah, I would say that as the partner to assess in this particular case examples that Jorge brings to bear. I think we talk a lot about value-based, but value-based can't be only seen in a vacuum. Value-based is only one component of, I think, additional initiatives. For example, good formula and utilization management. I do see a lot of interrelationships playing into this as time goes on. And I think the value-based arrangements and how drugs perform in a real world versus the study world will take on more merit on how drugs get accepted or provided access, and utilization management initiatives, as Jorge also stated. It's just interesting because in his population, where we normally see, approximately 21% of the U.S. population is covered by Medicaid or CHIP. In Puerto Rico, that number is 40%. And so it's a much more needier population in terms of really needing the services that I think George has talked about putting together. And it's great to see some of the initial successes out of that. Lastly, I would say, in terms of the multiple sclerosis program that we did that George mentioned earlier, I think it was one of the first programs in any state Medicaid plan that was brought to bear. And what it really showed was the beginnings of what we can probably do working together to really ensure medication adherence and holding pharmaceutical companies accountable when drug discontinuation happens as a result of a side effect sequela associated, to a drug. And so I think that we learned a lot there. I think we're still nascent as an industry, as in learning more about the concepts of value-based medicine or value-based agreements. And I think that the future is bright.
And what's interesting with these recurring themes, Delphine, is that and I want to touch a little bit on the regulatory barriers that you evoked, because I've been working with a medical device manufacturer on a really value-based contracting program that is designed to show the effect of that device over time. And currently, we're kind of blocked from getting to the starting gate because of the concerns of the delivery, one of the delivery systems that try and engage with about the perception of getting something in exchange for, some value in exchange for participating in the program, when in fact, I think it's pretty clear cut that there's no exchange of favors or quid pro quo or anything else. But that lack of clarity in the regulatory environment, I think, is an impediment to some of these value-based contracting. And when you step out of that, the key elements that drive value-based payments and contracting on the delivery side are the same. It's about transparency. So being able to have an exchange of information between the payer party, the provider, or whoever the deliverer of the service is, about the terms and conditions, about the services themselves. So you need to have good elements of transparency. You need to have time. And this is where I think the challenge for commercial payers always kicks in, because I think Javier mentioned this, which is if you know that you're only going to keep the plan member for a short period of time, why would you bother investing in things that actually have a relatively longer term payoff? But that's not the case for employers, because most employers end up by keeping their employees for a relatively long period of time. And that's doubly true for a lot of state employees or federal employees who have a tendency to stay in that particular employment for almost their entire career. And so when I look at examples of what has worked, we're supporting a program for the state employee plan of the state of Connecticut that has about 250,000 covered lives. And the goal there is to improve outcomes over time, but not just the clinical outcomes, the financial outcomes. And Jorge mentioned the importance of the clinical outcomes and being able to track those over time. We all know that the endpoint is always death, but how you get there and the quality of life between this point and that point is ultimately what matters. But the second important element is what are the expenditures that you're going to incur as you either stabilize the management of those patients or in some cases improve it. And you have to bring both of these together. In fact, in value-based contracting for either medical devices or pharmaceutical products, at the core is, can you justify the price that is being paid for that particular therapy? So we're always looking at the clinical outcomes and the endpoint, but it's in relationship in large part to the price that you pay. And ultimately, the success of these programs rests on the competitive nature of either the medical device manufacturer, the pharmaceutical company, or the providers. And that a competitive spirit can only exist if you create an environment in which you have competition. So there's no reason for a medical device manufacturer or pharmaceutical company to worry about value-based contracts if they have a monopoly.
Yeah.
There's no reason for a provider organization, whether it's a health system, a hospital, or a very large physician group, if they hold a geographic monopoly. So at the core, part of that regulatory environment is also having an environment in which you keep an eye on market consolidation and have some policies that favor market competition, because you really want to be able to then use the value-based payments and contracting as a mechanism to accelerate the competition in the market and drive towards better clinical outcomes at a reasonable price.
And I mean, there's so many things you touched on, just a couple. I mean, I think we're seeing an increase in antitrust enforcement in the healthcare space. Definitely not compared to other areas, but as there's been an increase in consolidation, Einstein being the most recent example. But yeah, I mean, there needs to be an incentive, and to your point, a population that's going to be part of the plan for an ongoing basis. You wonder if unions are a great example. And when you were talking about the regulatory scheme, you start talking about remuneration, exchange of remuneration, Medicare beneficiaries kick back and you get that immediate, response, right? Like, we're not going to go there. And then you add in a change in regs when in already a gray area, it just increases the hesitancy. And I think what I've found is that as more and more systems engage in value-based contracting, and their legal teams are more familiar. But when it is your first experience, there is a lot of hesitation that this is going to be a compliance problem from the outset. So the regulatory relief or clarity, it doesn't necessarily need to be complete relief. Yeah, it's clarity. You're not going to get rid of the anti-kickback statute, but at least some clarity.
Well, there's nothing that paralyzes business more than lack of clarity.
Lack of clarity, lack of transparency, lack of accountability, and that's maybe, it's a great combo. So all that said, we know that companies need to come together, whether you're the payer, whether you're the provider, if you're, pharma, physicians, I've been at the table where, no one's willing to give and we don't get anywhere, and life sciences companies. So, if you grab this one, what should a life science company keep in mind when thinking about engaging in a performance-based contract? And then same considerations for the payers and for the providers that are on the other side, or let's not frame it as other side, but are partnering in this relationship. And what are the key considerations that, based on your experience and knowledge, you would share?
Yeah, what I would say is to life science companies and also the payers, these are primarily the two stakeholders that will come together. Is, I think it's important to come in with an open mind of what the possibilities, of a good value-based partnership can create for all of them, right? And I've got 6 points that I'll quickly go through. And number one is the partnership has to allow for an evolution of experiences that will allow us to learn more about these new concepts, right, for both sides, right? Two, the agreement that comes up with, and I've dealt with various agreements on this topic, have to be simple. Sometimes we try to make it too Star Wars, too complicated, and it just doesn't go anywhere. And there's no alignment, no agreement, no way. It's got to be simple, or at least not overly complicated. Three, I think that there need to be outcome endpoints that are established on clinical value have to be easy to measure and reconcile. remember, there's a financial transaction that's also happening here potentially, and there needs to be fairness in how that gets scored. I think there needs to be enough value in the agreement to make it worthwhile for the investments that we're going to need to happen in order to pull this through. 5, I think there needs to be a willingness to reinvest the learnings and be willing to make long-term investments, right, in establishing a platform for future innovations and promoting, this value-based change from volume to quality, right, and that's something that needs a long investment cycle. I think Francois mentioned it too, like and George, right, with terms of, this is not a short-term thing that we're talking about. A lot of the specialty drugs that are coming out are high cost, high risk, type of therapeutic conditions or orphan conditions. And so these are not going to go away anytime soon. 6, I think that they have to, understand that offering like from a life science company perspective, and how I think future formulary P&T committees are going to come together to try to think about this. I think life science companies have to believe in their heart that value-based capabilities or deals are maybe the differentiator in a class that's very competitive. That if they're willing to put, their accountability behind their product, that might be the differentiating versus the competition. Or, if they want more rapid adoption of these very expensive specialty drugs that are coming from these orphan conditions, where we have over 7,000 different type of orphan therapeutic disease states, right? But we only have drugs for 5% of them. So we're drowning as a healthcare industry and having to pay for all these expensive drugs, but there's still 95% of the orphan therapeutic disease states that are out there that don't have therapies yet for, right? So I think that if they want more rapid adoption, they're going to have to stand behind. And like oftentimes, some of these drugs get approved through special accelerated processes after a clinical phase 2 approach, right? Which now means that these drugs are coming out to market without a no track record of real strong efficacy and safety. And so if they want payers to step up and start covering these products, they're going to have to think about what the value-based arrangement is, so that they can take risk and make additional investments as well, because they may not be going through a phase 3 or phase 4 study, right? Yeah. Finally, there's just 2 examples. One example, a drug called Zolgensma, which is for spinal muscular atrophy. This is a $2.25 million drug, right? So interestingly, Novartis, the drug company, has brought this out, and they have created special payment programs so where payers can pay it over a 5-year period. And they've also stepped up from a value-based perspective to offer, partial rebates in terms of their drug not meeting their clinical endpoints. So I think we're going to see more of this as time goes on. So those would be some of the thoughts I have regarding the question you mentioned.
I think the differentiator those are all great points. The differentiator, those that can figure out how to leverage it, the mechanism, and there have been other mechanisms, whether it's the ACO or the clinically integrated networks, that really never quite gained the traction. No one could quite figure them out to maximize them. Francois or Jorge, again, what perspective would you bring? What are the key things to think about when you're coming to the table?
Well, Javier mentioned the fact that he would like to keep these contracts simple, and I'm all for simplicity. But I think it's a great challenge to keep the contract really simple, because value-based contracting in many respects can be in the eye of the beholder. So good definitions are essential so everybody understands what we're talking about when we talk about the value that this contract has to provide in agreement with its own terms. So I would suggest 4 things. My list is a little bit shorter than Javier's, but 4 things that I would look into this, into value-based contracting. One of them is that unlike our common fee-for-service arrangements, value-based contracting is not a fire and forget proposition. I think we have to focus on the fact that making it work requires a lot of joint effort on the part of all the parties involved in the value-based contract. There has to be constant communication. There has to be an openness in talking with everybody as time goes by, because this is not a simple transaction that takes place because a service was provided. We can have to actually track a number of things across time, and that requires a lot of coordination and a lot of exchange of information, which takes me to info exchange. It would be a very good thing that the contract sets forth in advance of anything starting what type of information we're going to be exchanging with what frequency, and what we're going to be looking at in terms of exchanging information, which is essential. And I know, Francois, I know, Javier, it's all the different regulatory issues and the trust issues and the anti-kickback issues that come to visit us again. But if we don't have a competent exchange of information as time goes by, there is no way that we can actually know if this thing is working or not. Thirdly, the definition of outcomes is something very important, especially when we're dealing with chronic disease or very difficult to treat disease. And the outcomes have to be defined at the beginning. Without a clear definition of outcomes, we cannot really ascertain whether the value of the contract that we're putting together has been achieved or not. What are we looking at? A decrease in symptoms? Are we looking at an increase in active days? Are we looking at the preservation of function of limb or organ? What is it we're going to be measuring in terms of saying, hey, success, this is the outcome we were looking for? That is going to take a lot of clinical work and a lot of definitions beforehand, even before we go into the contracting thing. And finally, this is something that we always have to put on the table, because as opposed to a simple contract like a fee-for-service contract, when you have a value-based contract, there are the issues of sharing risk to some extent, and there is the issue of both parties working to make a person either get better or not get worse, which is in turn another way of saying we're going to keep these people out of the healthcare system, because that is going to be our definition of success. So the incentives have to be properly aligned so the whole thing makes sense for the participants in the value-based contracting. And aligning those incentives is something that has been proven not so easy when you're putting together one of these contracts. So that I would add those four elements as something we have to look at when we're looking into the development of competent and useful value-based contracts. And I think that if we can tackle these and the rest of the elements that Javier and Francois have put on the table, we would be on our way to be much better in putting together these contracts and achieving the goals of contracting, which is actual good outcomes at a lower price for the whole system.
Yeah, it's interesting because, ultimately the probably the single biggest underlying theme and corresponding challenge, whether you're looking at value-based contracting in the delivery system with the network, or value-based contracting with specific therapies, treatments, and medical devices, is that you ultimately are moving from an environment and a market in which the supplier sets a price at whatever threshold they feel they can get away with. I mean, literally, that's the way it works, right? And so it's not as if it's a fantastic price. The price discovery process in healthcare is aim as high as you can until you get knocked down, which is not the way rational markets work. And so moving away from that isn't simply a question of getting to value, but it's fundamentally recognizing that you can no longer be the fundamental price setter that you are today. And that you're going to have to enter into a real negotiation about price, and the price has to be commensurate to the value that you're delivering, whether it's the combination of services for the management and treatment of a particular condition, or the therapeutic effect of a specific medical device or pharmaceutical product. And that's the mind shift, right? Which is, how do organizations who are solely focused on top line revenue growth shift that focus to something that's more akin to getting, reasonable margins, healthy margins by extracting and helping to extract greater value for what they're supplying into the industry. So it's that's a huge challenge, right? And I on the delivery system side, we see this effect starkly, and I think we also see it in medical devices and pharmaceuticals, because in the delivery system, when you're a physician group practice, or whether it's multi-specialty or single, your fixed costs are significantly lower. Your debt burden is, very, very low, sometimes non-existent, which gives you a tremendous amount of flexibility to pivot in this new world of patient capture, patient margin, value creation, as opposed to the organizations who have saddled themselves with unbelievable debt loads and fixed expenses, partially because they weren't worried about the tomorrow. And if you build a business that's solely focused on just ever increasing prices for whatever you dish out, which helps you cover whatever insane expense loads you have, then it's a real it's more than a challenge, it's an existential dilemma to get from one model to another model, and yet there's no choice. Right? Unless, again, you're in a situation in which you can continue to extract monopoly rent for some degree of time, there's no choice but to pivot.
I remember physicians saying to me, well, I hope to retire by the time this really gets any traction, right? Like, this is not going to be my problem. This will be the younger physician's problem. And then the economy didn't perform the way everybody hoped, and they're still in the game. But it is. This is a fundamental, to your point of how do you set prices, eventually maybe your lawyer says, is that fair market value and commercially reasonable? Because it seems like we're paying, through the roof for this. But it is a very different price setting market than other markets. And to the point of the contract, I think what I'm hearing, and hope the audience hears, is, you want to make it so it is understandable and operational. Because unlike certain contracts where you buy your, X widget and you put the contract over on the shelf, this is going to be a living agreement. And one of the themes that I hear over and over is longevity. You're going to be trusted partners with a stake in a long-term relationship. And that contract needs to be understandable and flexible enough that it can survive. Because I've seen too many times, even on something like measurement, where the parties will come back to me and say, turns out we couldn't actually measure that, right? And I'm like, okay, well, what? And we still need to pay them now, but we can't quite figure out if they made it, right? So we spent all this time on the contract language, but nobody tried to figure out, or did, whether if it's retention of limb, do you just count that by whole limb, partial limb, so it needs to be a living agreement that you can work with, because it's not just making sure that you avoid compliance issues entering into the agreement, but that you don't have dissatisfied parties and regulatory risk when you're paying out on nothing. So we've talked about, clinical outcomes, measurable standards. Francois, you talked about the top line revenue, which is a critical point. Accountability, because we know that's so critical. To have accountability, all parties, accountability, consumers. Javier, I'd love to hear from you, your thoughts on, how have we seen success with accountability, or going forward, how do we increase accountability in value-based contracting arrangements?
Well, I'll take a first stab at that, Delphine. And I think I'm going to steal some of the statements that Francois put on the table just a few minutes ago. I think that accountability could be summarized indicating that this drug or this device will in actuality provide an improvement in outcomes as the parties have set forth. And if this improvement in the agreed outcomes does not occur within the time frame agreed, there should be some kind of economic penalty that would follow the non-performance of the drug or the device. I think that is essential. We hear about so many products that come out there, both drugs and devices that are supposed to be the greatest and best. And when we try them on people, the actual effect of the drug is only incrementally, marginally better than existing drugs or existing devices. So we're paying a whole boatload of money for this newfangled drug or device, and we could have actually gone with the old one, which was much cheaper, and tried, and the clinical results would have been more or less the same. So I would think that accountability will obligate, will move the party that's making the representations to be clear about what the device or drug does and cannot do, and will tailor the expectations of the contract to the actual performance expected, and not some pie in the sky presentation of a miracle cure that will not occur.
And to that point, ironically, while COVID has given appropriate shining light on the pharmaceutical industry, it's also raised expectations massively from consumers, because we're now looking and saying, well, you could cure this in less than a year. Why not cancer? Why not, why do we have to pay X millions of dollars a dose for just an incremental improvement in the outcome of a patient having a complex condition, when the industry got together and essentially solved a existential threat of most of humanity in less than 9 months?
And a lot of consumers don't realize it was building on existing research. There have been studies on the general population that think the vaccine came from scratch. So to further your point of, well, hey, high expectations now, what else can you do and do so quickly? So Javier, your thoughts on—
I mean, these Francois and George, I think, covered good ground here. I think, I think accountability, holding these pharmaceutical manufacturers accountable needs to continue. I think that, we have to think about, again, taking baby steps, right? In terms of creating I think getting manufacturers comfortable with taking a risk, right? They've been very risk averse. I think if we can continue to push them to take on more risk, and we can do that by how we evaluate drug access in the future, right? So that we create the pathway that they have to follow, I think is important. But I think keeping it simple to focusing on discontinuation of therapy, looking at some negative medical outcomes that could happen, or events like we're talking about a drug like Repatha, it's heart attacks. If we're talking about an MS drug, it's a relapsing event, and things like that. I think we can start building the track for that. I think what's important, I don't think it's been emphasized too much today, is the importance of data. And the analytics and the connectivity. And that is not so easy when you're trying to connect different disparate pieces of the healthcare system and together, because you need that data to come together to create to measure those measurable outcomes that we've been talking about, that George just mentioned is so difficult. And lastly, I think it's important that payers in general have a lot of actuaries. They like predictability. They set premiums, right? Value-based arrangements right now are unpredictable. So you can see why maybe there's a slowness, right, to get there, is because value-based arrangements aren't giving these health payers the predictability they need for their modeling, right? And I think that's something with better data and better experiences that we'll get with the evolving value-based arrangements that I think are going to continue to evolve. I think that'll help better inform future decisions for the future.
So let's talk about data. Let's talk about the power of data. I mean, we know more and more, right? We've seen an acceleration with COVID of technological adaptation, which is not, which is part of the data. But how do you, when we talk about, pulling the data together along the continuum of care, where do you see the opportunities and where do you see the challenges? Is it connecting EHRs? Is it, where are we going to mine that data between payers? Let's put aside any type of, data sharing regulatory concerns. But if you had a, magic wand, what would you do to increase sharing of data? Because it's a challenge. It's a real challenge, even between physicians in the same health system.
Mm-hmm.
Yeah, it is, but
sorry, Francois. Go ahead.
It is. There's no question about it, and I also think that there's probably far too much money being spent on trying to solve a problem that sometimes doesn't necessarily require brute force. For most of what we're speaking about today, you need a parsimonious set of data. And I know I mentioned this in the example around the diabetes endpoints. You're looking for very specific subsets of information, and aggregating them doesn't take an inhuman effort. It really requires the willingness of the participating providers to share a parsimonious set of information from their own files. And the same thing holds true with payers. And so I've tried to stay away and steer away from we need the next batch of funding for the next batch of health information exchanges and whatever. I think what we've learned in all of our work is that you can find the data that you need to make the programs work. And ultimately, as we get into more and more accountability, more and more value-based contracts, focusing on the right outcomes and paying for those outcomes, the delivery system, all the information blocking, all the rest of that stuff is going to have to be resolved by those who are today benefiting from the information blocking. So as much as it's always a challenge, we spend more time on data than I care to ever speak about. But at the end of the day, we spend that time because it's the struggle of extracting it from those who just simply don't want to share it. And so without getting into the regulatory issues, the data exists and they're not that difficult to assemble when the parties are willing to share it.
And that's a great practical takeaway. I mean, if we pull together, our 10 value-based contracting sort of myths, it's, is it really information blocking that's preventing it, or is it you just don't want to give it to me? Yeah. A lot of, I think if you're in the audience, a lot of angles to consider, great insight. I mean, this is it's an evolving area. It's fundamental shift. Even if you're just tangentially interested, I would recommend that you really follow value-based contracting, because it will transform our healthcare delivery system and the way we pay for it, invest in, access. I'd love if in our final time together, you could each share with the audience some takeaways. What you want them to leave our conversation with as they move on in their experience with value-based contracting. So who wants to go first?
I'll go first, Delphine.
Go, George.
Right.
So here's my takeaways. I think that maybe we have been a little bit critical and even skeptical about the paper. I mean, the role that value-based contracting plays in our healthcare system. But I understand that it is an integral part of the leap away from the traditional provision of healthcare. And I think that properly developed and properly put together, in addition to other changes that have to occur in the system, value-based contracting is a definite stepping stone in moving away from the old paradigm into a new paradigm. I also said maybe earlier in the presentation that we cannot disconnect the value-based contracting from the triple aim, we have to improve the experience of care, improve the health of populations, and we have to reduce the per capita cost of the provision of healthcare. So value-based contracting inserts itself directly and very congruently into the triple aim that has been put out there for many years as the gold standard of where we want to take our healthcare system into the future. And finally, I think that VBC is a potent enhancer to move away from sick care into healthcare. I think that we are still saddled by a tradition of episodic and reactive healthcare. And I think that VBC would allow us an entrance, a portal towards longitudinal and proactive care. And those would be maybe the three main points that I'd like to make. And I think that they segue pretty well with the different concepts that have been put forth by Francois and by Javier.
Thank you, George.
Thank you.
You know, my key takeaways, you know, as the audience listens in is, you know, to date, you know, value-based contracting has been slow to catch on because payers lack the necessary data at times regarding the patient outcomes, the connectivity of data, all the steps in between that are necessary. And pharmaceutical manufacturers have been reluctant, right, to adopt these new models because it's all about risk-based and they're not sure about that. Plus regulatory environments, as we've talked about it, not made it very conducive for them to do that. Two, I think that, you know, successful value-based contracting requires more advanced data analytics and interoperability. We didn't really talk too much about that, but, you know, the APIs and connecting systems, as Francois says, the data sits there. Business practices have prevented us from really connecting. But there's a lot of standards and technology. The technology is here to make that a real easy thing to deal with, and we've got to figure out how to do that. Lastly, I think value-based contracting, as George said, has the potential to significantly improve the cost and quality of care, right, and accelerate a broader shift from quantity to, you know, to value in our healthcare ecosystem. And I think it's something that I'm excited to see continue.
And Delphine, the upshot for me is really that the current incumbents in the system who have just benefited from the status quo are also in their own worst enemies. And I was asked a couple of years ago what I thought would happen in the following decade. And of course, it's always dangerous to make any prediction. But one of the things I said is, I believe that the healthcare system has 2 election cycles to figure out how to get out of its own way. Because if it doesn't, it will be dictated to by Congress. And if you look at what's being proposed today or will be proposed over the next several months to the Congress in the U.S., we're leaning closer and closer to much more formal regulation of the industry. And so I would say to all of the incumbents is, like it or not, you have 2 choices. You either embrace the value-based payment and value-based contracting world, or you will face severe regulation.
And I'll add to that and keep track of the regulations. And I appreciate that they're coming in fast and furious and that many of them are conflicting with prior regulations. We can't stress enough the importance of staying on top of regulatory changes. It seems that we could have a whole conversation around value-based contracting and data interoperability and where the challenges and opportunities are there. So really want to thank you. I think COVID, post-COVID is a time where hopefully we will have seen both the worst aspects of our health system and the best of our health industry, and be inspired to really make some changes so that we're not getting sicker and sicker every year, yet spending more and more money on our health care. So thank you. I hope that the audience, like me, was both fascinated and inspired by our conversation today. So thank you to our host, and I'll hand it back over.
Thanks, Delphine, for moderating such an engaging and informative discussion. I thought slow adoption of value-based care was just only about people wanting to do business as usual and not wanting to adopt new practices that might improve patient outcomes. But it seems like there's a lot of legal and regulatory challenges that are sort of standing in the way. So thank you so much for that. I really, really enjoyed the discussion. Thank you again.